Okay, well, hi everyone. Welcome. Uh, Good to be here with you today. My name is Audrey Gay, and I am the organizer on the team at the BC Health Coalition. I use she, her pronouns, and I'll be uh, facilitating us through this conversation today. I'm really excited to be talking about some of the ways that equity-deserving communities face barriers to access healthcare. I can't wait to dive in to that conversation. Um, Before we begin, I do want to take a moment and acknowledge that I'm joining today from unceded and occupied territories of the Musqueam, Squamish, and Tsleil-Waututh nations in what's colonially known as Vancouver. And I know many of us are joining from different lands and homelands across the province. So want to invite you to take a moment and be grounded in the reality that we live in a world, and many of us, we all use a healthcare system that has a history of colonialism and indigenous specific racism. And the system was designed so that people like me and my ancestors can benefit. And it was also based on exclusion and segregation for Indigenous people that even included experimentation without consent on children and the denial of cultural medicines and healing. So today it's our responsibility to reclaim our healthcare system and to set a new course that's truly inclusive. And we know that that means that one size does not fit all. It means that we need specific work to be done, led by communities that are currently facing these barriers. And so I do want to acknowledge that includes Indigenous people. Also Black people of color, and other communities that we're not going to really dive into today, people with disabilities, people who use drugs, people in rural and remote communities. There's so many, and so we're just talking about a few today, and that's a step in our learning journey. So thanks again for being on board for this journey. Just gonna share my screen and go through a few pieces of housekeeping here. Give me a sec there. Getting to full screen. So if you're not familiar with the BC Health Coalition, as this is your first time, our mission is to defend our healthcare system against privatization and also expand Medicare or public health care in Canada to improve access, to improve what's covered under our provincial public plans, including things like dental, vision, mental health care, and many other things that currently don't get covered. And we also work to advance evidence-based public solutions on healthcare issues. And so that's connected to what we're doing here today. We've been in this Lunch and Learn series where we're diving into some of the visions and solutions that will that the evidence says will improve our healthcare system. And so I invite you to check out our previous sessions. We did one on community-driven primary care solutions with a focus on the community health center model. And the previous one was about extra billing and the different ways that people are charged out-of-pocket fees to access healthcare in BC. So this is one of our ways that this year we're kind of doing our education work around the solutions that we know can make a big difference in terms of improving our healthcare system, and they're just not yet implemented. And we're using all of this and building up to a campaign during the provincial election period where we'll be putting forward some of these evidence-based solutions as real healthcare solutions we want to see our candidates commit to leading on. So stay tuned, more info on that. So just to give you a sense of where we're heading, just I'll shut up briefly, and you'll get to meet our panelists, and then they've prepared some presentations about the work that they do and the organizations they work for. So we'll hear from them for most of the time. And then today we're trying something a bit different in terms of the Q&A is actually going to be a discussion between our panelists. So we'll give them a chance to ask questions from each other. And I think that'll be just a really rich way to hear more from them and to have that kind of cross-pollination of ideas. So I'm excited for that. At the request of our guests, we've disabled the chat for today to minimize distraction. And so I've put up here on the screen our email address at the Health Coalition, and please do use that to send in any questions or comments or feedback that you have. You should also have the ability to chat with me as the host directly. So I'm very happy to, as much as I'm able, I'll keep an eye on that. But the goal is really to minimize distractions and focus on the content that our guests have prepared. So we're going to give that a try for today. I think that's going to be it for me. So my preference when hosting these kinds of conversations is to let guests introduce themselves. I think I always find that so much more interesting than reading a bio. And so I've asked all of them to just get us started with just a brief introduction. Who are you and what's the question I gave you? Can you tell us a bit about yourself and how you ended up doing your current advocacy work? And don't go too much into your work because we'll hear from that in your presentation, but this is more about you and how you ended up doing this. So maybe we'll go backwards. I don't know if that's a bit of a curveball from the order of presentations. Cyndia, do you want to get us started?
Okay, well, thank you so much for having the opportunity to be here today and to take part of this. I am a person whose background is a colonial settler. I came to Canada as a result of my opposition to the war in Vietnam in 1970. I've lived in Vancouver ever since. I came out as a lesbian in 1976, and I guess I've been an advocate for my community and myself about that ever since. Most of the information that I'm talking about today is from the group Quirk-e, which has been going for 18 years, but I've been part of it ever since I retired. However, an 84-year-old friend of mine joined at the beginning, and I had to wait until I was retired. I'm also a member of the board of Reach Community Health Center, but I'm not really speaking on behalf of that group today, but it does inform some of the knowledge I have. During my career, I worked in the field of home support for 35 years for a nonprofit and then for Vancouver Coastal Health, which means that I was a senior serving person long before I became a senior myself. Thank you.
That's very interesting. Thanks, Cyndia. Let's go to Beverly.
Hi, everyone. My name is Beverly. I work at Yarrow Society in Vancouver, Chinatown, and I'm also a settler of Han Chinese descent. I got involved in the work when I was still a college student about a decade ago. Yeah, I had just come back from visiting Taiwan, China, and Hong Kong for the first time, and I wanted to stay connected with my culture. So I started volunteering with Yarrow when it was before it was a nonprofit and it was still known as Youth for Chinese Seniors. So just a small grassroots collective of a lot of college students or new grads who are trying to sort of find our footing in Chinatown, where a lot of us had grown up or had some sort of connection to through our families, and also sort of deal with the changes in the neighborhood, especially the pretty aggressive displacement and gentrification that's been happening for the past 2 decades or so. yeah, and then I moved away from the city and then got this job about 3 years ago in the middle of the pandemic. So that's when we were doing a lot of vaccine clinics and vaccine support for seniors, Chinese seniors who don't speak English. Um, and yeah, we continue that sort of language access, cultural access work today.
Thanks, Beverly. Let's go to Omar and then Ingrid.
Hi, my name is Omar. I use him pronouns. I'm a member of Sanctuary Health. Calling in today from unceded territories, the Musqueam, Squamish, and Tsleil-Waututh people. I was born and raised in just Burke-Whitlam area, the territories, Quick-Whitlam and other Coast Salish speaking people. I've been a member of Sanctuary Health for about 10 years now. Started, I think, yeah, growing up in this community, and really, I think, like as a child, like sort of believing in the multicultural narrative that was put forward through Canada, and then seeing the way that, as getting older, seeing the way that migrants and refugees are treated in this country, really having that narrative shattered, and wanting to stand in solidarity with people who are coming here and are our neighbors and friends and community.
Thanks, Omar. Ingrid, how about you?
Hello, everyone. Good afternoon. Buenas tardes. My name is Ingrid. I am also a member of Sanctuary Health Collective, and been a member, I don't know, maybe a little longer than Omar or shorter than Omar. I have no idea. My sense of time is lost since COVID. And I am originally, I came originally from Guatemala in the early 90s as a refugee fleeing death threats and persecution with my partner. And as soon as we came, we started getting involved in some of the support that was going on for refugees and for refugee claimants, especially in the downtown east side, and have been working in the downtown east side for the last 32 years. And just recently left my position at Watari Counseling and Support Services, and now I'm working pay work with the Migrant Worker Center. And the reason we did that because we were coming from persecution, and we saw how people were struggling so much here with the system, and how the system makes people vulnerable and isolates them, especially people of color, Indigenous or Black people. So we got involved with many different things that were going on to support the community. So I guess I focus my work a lot on social justice and access to healthcare, education, and especially now supporting a campaign for status for all. It's hard when I am asked to talk about myself, it's like, what do I say? And, how do I frame it? I never know. It's kind of hard to talk about yourself. So anyway, I'm going to leave it there because I don't know what else to say.
That's wonderful. That's
you.
a great start. Well, thanks so much. And actually, we're going to stick with you, Ingrid and Omar, and you'll get us started. So I basically we will have three presentations from Ingrid and Omar, Bev and Cyndia, and I've asked them each to tell us a bit about the organizations that they work with, and the stories that illustrate barriers to healthcare access in their communities, and then if there's any solutions that you're working on, things that your communities are asking for or working towards, we want to hear about those and find out how we can support them. The mic is yours, Omar and Ingrid.
Yeah, thank you, Audrey. I'll start off, and Ingrid will, I'm sure will fill in everything I'm missing. So yeah, Sanctuary Health is a grassroots collective, meaning that none of us are paid. This is all sort of work we do as community members, with community members. Sanctuary Health was started back in 2013, a little bit before my time joining, in response to the cuts to the interim federal health program that were happening at the time, and those were cuts for healthcare for refugee claimants. What some of the things that immediately started working on is like organizing clinics with volunteer doctors and healthcare professionals to try to support those needs. And one of the things that in those clinics that it's not just refugee claimants who have been cut off, but there's many people in our society who are denied access to healthcare. And I think seeing Audrey's slides initially when we're looking at like the priorities of like stopping privatization of our healthcare system, I think that it really ties in a way that there is a bit of a stealth privatization going on, in that when we talk about universal healthcare is supposed to be promised to all of our community members living here in Canada, but more and more people are being excluded from access to healthcare services, access to MSP, tied to their immigration status. When immigration status is harder to get and easier to lose, and more people are here on like different temporary statuses, that can result in like not having status at all. There's a huge gaps in our system in terms of the access people have, and so that the fear of debt, something that that our healthcare system is supposed to avoid, that you shouldn't be afraid to access healthcare services or like be unable to afford healthcare services, is something that's very real for a lot of people in our community. So many people who receive these huge bills, so Sanctuary Health, one of the things that we've done is like we organize around sanctuary city principles. So access for all and access without fear. So access for all means like people should be really able to receive services based on need, not based on their immigration status. And access without fear means that they should be able to access the services without fear of a huge bill, without fear of their information being shared with the Canada Border Services Agency, or accessing these services will result in deportation. And so those are the principles that we organize around, and we've had some successes in terms of finding places like the Reach Community Health Center and the Reach Urgent Primary Care Center that will now serve people without immigration status. But if someone sees a doctor and the doctor says, "Oh, you need to go to the hospital," that fear of a huge bill is something that makes access, like many people are afraid to access the hospital, afraid to access because of the bill. And that privatization the system. Or we have like Ingrid, you can probably speak more to this than me, like you have farm workers who come for like less than 6 months, and their employer is supposed to buy for them private health insurance, and yet that creates all sorts of issues. One, like the coverage isn't high enough, so people end up in hospitals, and then it gets covered a certain amount, and then they still get a huge bill on top of that. You also often with private health insurance have to pay up front and then get reimbursed later, and workers don't have that. And hospitals start immediately often talking to workers about what they call medical repatriation. And that's, Ingrid, do you want to say a little bit about that?
Sure. Thanks, Omar. Yeah, that was really great. And yeah, the one thing I also wanted to add to what Omar was saying is that the reason Sanctuary Health was born was because we started getting a lot of calls, especially from women who were pregnant and did not have anywhere to go and receive prenatal and especially get access to giving birth. And a lot of these women were putting themselves in danger by not accessing healthcare, by not, I'm sorry, the cats here think that this is their table, so I'm really sorry about that. So not having that access was the main fact that led us to decide to call on a few allies, a few people we knew in this that were already in the system, and we called on nurses, doctors, and said, you know, what do we do? How do we support these women? Where do we send them? Do we wait for one of them to die along with their child before we act on this? And so that's a bit of how the whole idea of sanctuary health was born, because, you know, a lot of these women were desperate. And these were and continue to be women that are not here just because they want to be. These women are here because many of them have been brought by their partners under the false premises that they are gonna get a permanent resident status, or they're gonna get married and that kind of thing, and they fall in love and they just come with them. And once they are here, the partner starts abusing them, starts threatening them. As soon as they get pregnant, start saying, you know, if you have that child, I'm gonna take that child and report you and make you get deported back to your country. So these women are also living in a lot of fear and are also being traumatized for the whole experience. So that's why Sanctuary Health was born. And the other issue that Omar was touching on is agricultural migrant workers. And a lot of migrant workers who come to BC. We know that there's more than 10,000 workers that come to work in the different farms every year, that British Columbia brings them here to grow the fruit the fruit and the produce we eat, to grow the plants we put in our gardens. So they come here every year from different parts of the world, and they come here and have no access to healthcare. And it is very critical for the first 3 months, especially for them to get access to healthcare, because those are the times when they are feeling sad that they left everything behind to come to Canada and do this work. They left their families, they left their children. Those children many times are very convinced that these parents do not love them and they have abandoned them. So there is a lot of loss, a lot of grief and loss going on. So they get sick. And when they get sick and the farmer doesn't buy the insurance that he's supposed to be buying, or the employer doesn't buy the insurance, then we have a big problem, because many times they end up in hospital. During COVID, this was a huge challenge, because many of them ended up with COVID and ended up in hospital. So yeah, that is an issue, that it's an ongoing issue, and that we have been fighting for the 3-month wait period to end, period.
And yeah, just to talk about like what Ingrid mentioned about the pregnant woman, I think we're in a bit of like a full circle moment now where like this is still very much an issue 10 years later. In fact, like, and I think even like the volunteer resources that like maybe might have been available for are stretched so thin that there's so many women right now who are not getting access to even most basic prenatal care, not getting access to like gestational diabetes screenings, and we are worried right now that someone's going to die soon. Like, and that's I mean, like that. This is a fear that we have right now in terms of like the system not being there for our community members. And just in terms of what thing that we're doing and like something that I actively campaign on right now is that right now is a crucial moment where we're part of a wider national campaign with the Migrant Rights Network, which is a group of migrant justice organizations across the country that are fighting for a regularization plan, a broad and inclusive regularization plan. And it's a pitiable moment right now where the government may be considering soon. So I'm just going to share my screen real quick here. And I'm going to send Audrey in the chat these links that maybe you can post to the group that of actions that you can take. We're looking for letters of support from, if you're a part of an organization, for organizations for a broad and inclusive regularization program, as well as like individuals can try to call a minister in the next few days. Because part of this issue is like we have this healthcare system, and like sometimes we get in trouble, I get lost in the weeds, and like talk about like the very different specific immigration statuses that access MSP sometimes or IFHP sometimes, and like can really like those presentations get lost in that. But in the end, if we had immigration status for all, if we had permanent resident status for all, these distinctions, these weeds, we wouldn't have to get lost in those weeds, because we should just have, if you're living here and you're a member of our community, you should be able to access services like the rest of us. And so that's sort of the short pitch for the regularization campaign, and hope that organizations and individuals can support.
If I can add really quickly to what Omar was saying too, is that the other piece that you can do internally in your organization is, if you haven't adopted sanctuary policies, that you can look at adopting sanctuary policies in your workplace. And Omar and all the members of our collective and myself can help people navigate that. But that's a very important step into welcoming people who are here undocumented or with precarious immigration status, and that have a fear of accessing services because of CBSA getting a hold of them. So I think that's also very important. The campaign is super important. So please send that to your contacts. Ask everyone to join the campaign right now. This is one of the last pushes for this to become a reality. And we're very hopeful that with all of your support, this will be so, but also consider passing sanctuary policies in your own workplaces. The other piece is that Migrant Worker Center, along with Sanctuary Health, is also launching a campaign for the 3-month wait period to stop. So please let us know if you would like to be added to that. Maybe you can send a message to Audrey, and then Audrey can get a hold of me. Thank you so much, everyone. Really great seeing you all here.
Wonderful. Thanks so much, Omar and Ingrid. And I'm definitely happy to pass on anything that you send my way with the follow-up materials to everyone who registered for this. Yeah, thanks again for your presentation. So we're going to come back to you with some discussion later, but for now, let's move on to our next guest. So that's Beverly.
Hi, everyone. Can you hear me? Okay.
Yeah.
Okay, great. Yeah, I work at Yarrow Society in Chinatown, like I mentioned earlier, and although we incorporated as a nonprofit 6 years ago in spring 2018, before that, for about I think 4 or 5 years, it was just a group of Chinese youth, a lot of us in our 20s and 30s at the time. And we noticed that there were a lot of gaps in healthcare, namely with language access, as well as with services in the downtown east side. A lot of them are English only, or do not have Chinese speaking workers or drop-in hours. So we began as a grassroots initiative to fill in the gaps in healthcare and basic needs, so that we can remove barriers to fulfilling housing, health, and basic income needs that Chinese speaking low-income seniors in the downtown east side face. And even to this day, there hasn't been much structural change, unfortunately. So I think a lot of folks here know either through personal experience or through their work that folks who don't speak English or are BIPOC face a lot of barriers with accessing healthcare, face a lot of medical racism and discrimination and profiling. And it really, the healthcare system currently does not seek to prioritize the diverse language and cultural needs of the cities or the province's residents. And this was really clear to us during the pandemic, when a lot of messaging was unclear or contradictory, and it kind of built a lot of distrust with, at least in the Chinese community, and a lot of fear as well. That was already present in a very uncertain time. And when vaccines were being rolled out, a lot of that information was not clearly conveyed to the Chinese-speaking communities here. So there was a lot of panic and stress. And during that time, Yarrow worked with other Chinese senior outreach workers in the downtown east side. There's really only 5 or 6 at any given time. So at Yarrow, we had 1 at the time. We have 2 now. There was 1 at SRO Collaborative, 1 at Vancouver Second Mile Society, Carnegie, Strathcona, and then later on Raycam Community Center as well. So we worked together to push the Vancouver Coastal Health Authority to have specific community vaccine clinics here. And it was partially successful. We had thousands of Chinese speaking and Vietnamese speaking residents immunized, but it was a lot of labor that we had to provide, like nonprofit and community center workers, when it should have been the health authority hiring trained interpreters, like certified medical interpreters for that. And yeah, healthcare authorities and all levels of government to a certain extent continue to rely on nonprofit organizations and grassroots efforts or mutual aid networks, like Masks for East Van or Sanctuary Health and Yarrow, when there should be a wider systemic change instead. And so some of you may know that at Yarrow, we have one of our earliest, and I would say our flagship or most well-known program is the medical accompaniment program. And this started with pairing volunteers who speak Chinese languages with seniors who had specialist or hospital appointments to provide interpretation. And now we have an outreach worker who has a medical interpretation certificate from the SFU program. And we have been booking more PHSA appointments or booking more PHSA interpreters, and pushing for like wider language access. So yeah, again, not a lot of change from above other than the CT scans now speak Mandarin, I heard. So they have an automated voice inside. Yeah, so our medical accompaniment program continues, and it's very popular, not just in Chinatown, the downtown east side, and Strathcona. We receive a lot of external requests or referrals from organizations all over the Lower Mainland, just because it's difficult to find a similar service for Chinese-speaking seniors or patients. Yeah, and unfortunately, because of our mandate and funding, we have to turn those down, because yeah, our geographical focus is in the downtown east side. And then yeah, there are a few examples, unfortunately, of seniors that we know who've had complications with procedures that we believe could have been prevented if they were given proper interpreters and they were given their full diagnosis and prognosis options in their native language. We have heard from seniors that they feel pressured to make decisions or they feel judged or discriminated against for choosing certain options or choosing like traditional Chinese medicine over Western medicine or Western treatment. So yeah, there have been a few seniors who have had complications, and one of them ended up moving back to Hong Kong. And she said she's a lot happier there now, and she's able to access healthcare in Cantonese, like in her native language. And she said her health is also a lot better because of that. So we are very happy for her, but unfortunately, it just kind of highlights the ongoing issues in BC's healthcare system. And like Omar and Ingrid touched on, status is also an issue for some Chinese seniors. And we are seeing an influx of refugees, folks with refugee status coming in from Hong Kong, especially, including older seniors or older adults. Yeah, so I think the status for all is something that benefits everyone and benefits a lot of communities, and is something that is definitely long overdue. And I'll wrap up some solutions we're working on. We're continuing educational workshops with Chinese speaking pharmacists, dietitians, and physiotherapists. So we started that last year, where they hold workshop series with a small group of Chinatown seniors, like maybe 10 to 20. And they do a short presentation, they answer questions from seniors, and also offer like a lot of affordable options, or do some like myth busting as well. And hopefully this year we'll be continuing that. We're already in touch with the pharmacist that we worked with last year. And we're also hoping to contract one of the younger seniors who was a certified traditional Chinese medicine practitioner in China before she moved here, to give us workshops, and to see yeah, how we can support seniors better in that field, because some of us, like myself especially, we don't know too much about traditional Chinese medicine, and yeah, so I think that would just be beneficial for our whole team, not just the seniors. And we're moving more towards an advocacy focus again. I think before the pandemic, before I was on staff, there was an initiative called Language Access to Healthcare, and it was a committee of Yarrow staff, board, and like volunteers, like healthcare workers, working on this, but it kind of stopped during the pandemic because of yeah, like lockdown and just people's capacity. And we're continuing a holistic approach to healthcare and to healthy living. So we still have fully subsidized food and exercise programs, and our casework services to hopefully alleviate some of the like income barriers, or access to food barriers that seniors face.
Okay, well, thanks so much, Beverly. That was so much great information. I'm seeing claps in the chat videos. Stick with us, Beverly. We'll come back to you. Hopefully, we get some time for a couple of questions. And let's go to Cyndia next.
Good afternoon, everyone. I am really honored to be here, and I'm just taking a moment to pull up my remarks so that I can remember what I'm saying here. Here we go. So today I'm here to talk about two-spirit, lesbian, gay, bisexual, transgender, and asexual and intersex people who are 65 years and older And this is based on my experiences of being an older lesbian and a member of Quirk-e, which is the Queer Imaging and Writing Collective for Elders. And I'm going to screen share and show you what that's an acronym for. Just a minute. So it's an acronym for Queer Imaging and Writing Collective for Elders. And here's a picture of what we look like and who we are and a little bit of what we stand for. So I'm speaking, based on experiences, but at the end, I have some resources in which you can read some data if you're interested and want to about the entire community of queer elders. So Quirk-e's been going for 18 years, and with some turnover of people within it. Of course, some have passed away and aged out and new people join. We receive support from Britannia Community Centre and Community, which is BC's Queer, Trans and Resource Centre. And I'm going to use the term queer elders as a shorthand for LGBTQ2IAA++ seniors a lot of the time. So I want to start with an intersectional lens and recognize that queer seniors are part of every other community, and that all the barriers that affect those marginalizations affect us as well. So language, immigration status, being older, disabled, racialized, isolated, living alone, having income, housing, and food insecurity, all these social determinants of health function as barriers to accessing healthcare, and they affect us as well. In fact, queer seniors are overrepresented in every marginalized category and facing all these barriers. So, of course, the effect of this varies on different individuals, but it affects everyone. I want to talk about the barriers that specifically affect 2S LGBTQ plus elders. And the primary of this is ongoing and current effects of our past experiences of discrimination and stigma. So as elders, we have lived through decades of being criminalized, pathologized, and moralized for being who we are. We have fought to change these with great success, but it hasn't erased its effects on us. We're hyper aware that our progress is under attack, and not only in other countries or other provinces, but here as well. And we have not forgotten what a lack of human rights feels like. We were at risk of being jailed. Some of us received treatments like surgery without consent as infants for being intersex. Some of us were forced into involuntary psychiatric care. Most of us were separated from our faith communities, and some were subjected to harmful conversion therapy. One time, following an accident, my partner rushed me to the ER. And although I was having trouble finding words due to being in shock, the physician ignored and refused to acknowledge or communicate with my partner. We bear scars from these experiences. During the AIDS pandemic, gay and bisexual men in particular were treated as less worthy of care than others. They were seen as morally depraved, deserving to die, and as being an infectious threat to heterosexuals. So meanwhile, we witnessed hundreds of our loved ones die. And in the face of this, we created wonderful systems of support arising from our own community and spreading out into other parts of healthcare. And now, 30 plus years later, there are many supportive, compassionate, and knowledgeable healthcare providers. But that doesn't erase the memory of our past mistreatment. And even though we may expect by human rights standards and protocols that we will be treated with respect, dignity, and autonomy, we know some healthcare providers will and some may not. And we don't want to be blindsided by subtle or overt bigotry when we're at our most vulnerable, which is when we most urgently need healthcare. We strongly seek out services that we know to be safe. We tend to avoid the unknown until we see overt signs that we will be welcomed, such as rainbow signs or recommendations from friends. Many of us are retired, and this means that if we have found trusted primary care providers, they are retiring too. So who do we access next? The barrier of not knowing whether our healthcare will be affirming or not is especially intense for our members who are transgender or gender diverse. When providers discover that our bodies don't match their assumptions about what bodies should look like, providers may not give knowledgeable care. For example, screening a transgender woman for prostate cancer or a trans man for cervical cancer. Or those trusted to help us may even communicate disgust or disapproval. There's a case currently at the BC Supreme Court about a nurse who opposes treating transgender patients. And we follow this news closely and are affected by negative press, even if we have not personally experienced mistreatment. In addition, we treasure our independence. See, we try to live without those that don't accept us. Lesbians, in particular, draw self-esteem from being capable, self-reliant individuals who don't depend on husbands. A former dance teacher had to fall several times before agreeing to accept mobility aids. Visible forms of assistance can really challenge our sense of who we are. And we dread the need for residential care, which might mean going back into the closet, because even if the staff are caring, we can expect that many of the residents who come from our own generation will not be. Another persistent barrier is our reliance on chosen family, friends, not relatives. Many of us were rejected by biological family members. Many of us moved across the country or from other countries to be removed from such rejection. So even if our blood relatives have gradually become more accepting, they're now too far away or too old to provide the circles of support that we need if we become chronically or seriously ill. Some of us have children and grandchildren, but the majority do not. Many of us don't have partners or had partners who are now deceased. Because being asked being asked who is our next of kin is painful. And we want our chosen family treated as family, especially at the end of life. Sometimes they are, sometimes they aren't. I was a primary caregiver for an 84-year-old man who lived in my home. But when people discovered I wasn't his wife, I was his friend, I was treated with suspicion that I was financially abusing him by helping him. In conclusion, elder queer people may avoid accessing healthcare because despite the dangers to our health for doing so, it just seems safer not to. So for us, cultural safety is our most vital need in accessing healthcare. And sorry, I'm just going to share another screen so you can be referred to some resources about this. There we go. EGAL and Community are two Canadian-based organizations serving LGBTQI seniors, and they've done great studies about the needs of older adults. And within them, I think you can find resources that if you want to support culturally safe care in the organizations that you're part of, you can do so. Thank you.
Well, thank you so much, Cyndia. If you can send me in the chat the link to those, copy and paste those resources, then I can put them in the chat right away. And if we don't manage that, then I'll happily send it out with a follow-up email to everyone who's here. So we've got, I didn't have it in me to cut all of you off for timekeeping because you're all sharing such important things. So we've got just 5 minutes left for our discussion. I'm gonna suggest my kind of burning question at this point, but you can ignore it. And if any of our guests, panelists has like a question that you wanna kind of override that with, please jump in. But I'm just thinking, all of you have mentioned something about the experience of not feeling, not having trust in the healthcare system. So I'm wondering if that's that. So my question is like, do you have thoughts about what it would look like to move to being a much more trustworthy system for people? And you, as I said, you can ignore that. And if you have a question for another panelist, go for it. But I'm trying to pay attention to, yeah, Omar, Beverly, and Ingrid's screens for you to jump in.
Yeah, I think that there's so much that needs to be done to build a trusting system. Because I think something that because Sanctuary Health, we advocate for access to healthcare services. We also advocate for access to education and we navigate a whole bunch of systems. And something we've seen in like those different systems is that there needs to be change on many fronts. So sometimes in some contexts, there are people who are high up decision makers, policy makers who are saying, "Oh, we believe in this, we're on board," and doing something, but they don't train the people who are delivering the services. And then vice versa. Sometimes we have people who are service delivery and are really doing their best to create a welcoming environment, and yet they don't have the support from the people, the policies and people high up, and they're fighting against the systems. And so there really needs to be like work at all different levels to make sure that things are working together.
What about you, Cyndia? Any thoughts about that?
I'm aware that Reach Community Health Center, which I'm on board of, has an increasing number of people coming who don't have MSP. And as a sanctuary health organization, we serve them. And, you know, two of the biggest challenges I think that we have are accessing people's medical records and accessing medical tests that are necessary even to provide the proper care that we do at Reach. Is still, there's so many barriers to that. And Reach actually depends on a degree of donations just to cover some of those issues. And you know, this is a publicly funded healthcare place. We should not be relying on donations for people to receive essential healthcare services. And Reach should not be the only place doing this. Thanks.
Yeah, a lot of the great work that all of you are doing is you know, pretty geographically specific. So you know, I'm thinking of people in you know, outside of the Lower Mainland, rural and remote communities where all of these identities start to intersect in really complex ways, and so yeah, it's definitely on our mind as well. The added barriers of living in a remote and under-resourced area. Well, I think unless Beverly and Ingrid want to jump in, we're at time, so I might wrap us up. But just want to thank all of our guests so much for your time and the thought that you put time and thought into preparing for today. I know that many people who are here probably have their own stories that they would share, and so please do send us an email at the Health Coalition, because we really benefit from hearing these personal stories. It really makes these issues come alive. And just also I want to reiterate that we've only really scratched the surface of the different barriers that different communities face, and all of these things are intersectional. So if you've got a particular connection to a community that faces barriers, and you're doing some work to address that, I'd love to connect. Please reach out to us, and maybe you'll be a guest on our next webinar. And so I think I'll leave it at that for today. And just huge thanks to our guests. Please stay tuned for more email announcements about our next Lunch and Learn event in the series. We'll continue to talk about different communities' barriers to access, but also other aspects of where healthcare needs to go. So I think with that, I'm going to bid everyone farewell, and a wonderful rest of your day.
Thank you so much for organizing. Thank you,
Thank
Cyndia
you
and
so
Beverly.
much.
Thanks.
Yeah, thanks, Audrey. Thanks, everyone. Great to hear from you all.
Thank you. Thank you.
Thank you.